Our third topic by Dr. Anola again, please. Management of the parturient with cardiac.
Thank you. So I'm going to be talking about overall general management of the parturient with cardiac disease. And I'm going to hopefully reinforce some of the messages we've just heard from Professor Yang. Now, cardiac changes during pregnancy, I don't want to dwell on this too long. Professor Yang described this very eloquently. But just to go through it very briefly, massive physiological changes in pregnancy, and these, by the time you get to the third trimester, in particular labour, these can become even greater. And labour and the time of delivery is a really significant risk period for any woman with cardiac disease. Now, cardiac disease is difficult really to describe and study for all of us because it's an extremely heterogeneous group of patients. Cardiac disease can arise from congenital or acquired problems. You can have a woman who's presenting with a repaired or an unrepaired problem. You can have structural lesions related to the plumbing of the heart, or it can be valvular lesions, as we've just heard about. And also there can be electrophysiological problems. And often, cardiac problems go with syndromes that pose other problems for the anaesthetist, such as Marfan's or Ehlers-Danlos. So to study these patients is very difficult, and this is one of our first difficulties alluded to by my colleague, the previous speaker. Published research for individual conditions is very, very limited. We have very small numbers, very small case reports and case series, and at best, we could really say it was level C evidence. The major points of reference that I'm going to be using are the CARPREG study. It's quite old now, about 15 years older, a series from Canada of around about 1,000 patients. They're a heterogeneous group of patients, as I've mentioned. I'm also going to be talking a little bit about the UK maternal death inquiries. I would urge you to take a look at the European Cardiology Society guidelines in this area, and I'm going to mention ROPAC. Now, first of all, ROPAC, the previous speaker did mention this, the Registry of Pregnancy and Cardiac Disease. Now, this is an international collaboration led by the European Society of Cardiology, and they really want to try and accumulate as much data as possible on women presenting with a variety of cardiac disorders to really improve our knowledge and understanding in this area. And we've started to see some important publications emerging from this registry, and I'll mention at least one of these later on. The European Society of Cardiology guidelines in this area is a huge document. I think it's about 50 pages long. But if you want to just have something as a quick reference to have maybe available on your labour wards, this is the Essential Messages Summary, which is a much shorter document and really précises very nicely what the entire document says. And I have to say, I think I found that a little bit more readable than the whole document. Now, I mentioned the Maternal Confidential Death Inquiry, so this is called EMBRACE, which stands for Mothers and Babies, Reducing Risks Through Audit and Confidential Inquiry. Now, this is a series of reports that's been running in the UK from the mid-1950s. Reports used to be published every 3 years, but they're now published annually. And they look at maternal mortality from all causes. The most recent report was published on Wednesday, just a few days ago, and this report specifically focused on women who died from cardiac disease in pregnancy, and I'm going to be describing some of the findings of this report. This is maternal mortality by cause in the UK, and I don't think that the population in the UK is so different from the population in Kuwait. And as you can see, cardiac disease is the #1 cause of maternal death in the UK these days, by quite some way. Reassuringly, anaesthesia is way down that list. Now, what were the causes, or the individual causes of cardiac deaths in the UK in this EMBRACE report? Well, these were confined to ischemic deaths, deaths from valvular heart disease, essential hypertension, myocardial disease, and deaths from sudden adult death syndrome, which I'm going to talk a little bit more about. And when you compare this to the CARPREG study, published, as I said, about 15 years ago, you can see a similar broad variation in the types of cardiac disease that can present to you on the labour ward. Now, I think at this point, I would just like to make one point. I think that no matter where you work, whether you work in a teaching hospital or a smaller hospital or a private hospital, I think you must never believe that, oh, this is not a problem that's relevant to me, because I think any pregnant patient can present to you on the labour ward or in an antenatal clinic with a cardiac problem that hasn't been detected previously. And you may be one of the first people to meet this lady and be charged with meeting the challenges of looking after her. So this is not specialist work that a general anaesthetist is never going to come across. This is relevant to you, whatever area you work in. Now, anaesthetic management, I think, encompasses various points. I think early involvement of the anaesthetist, because I think the anaesthetist these days can increasingly be a linchpin for any patient with other comorbidity, not just obstetric patients, but any patients. I think it's becoming clear that anaesthesia, the role, is really evolving into more of a perioperative role. And I think that I wonder about anaesthetists in 10 years' time, will we be called perioperative physicians? And I wonder about those people who choose to specialise in obstetric anaesthesia, will we be obstetric, peri-obstetric physicians? Because the first thing that happens with a pregnant patient when they get sick is that the anaesthetist is called. And I think similarly, the first people that get called when a surgical patient becomes ill is the anaesthetist. And I think that our role is so much more than anaesthesia these days. So the first point I would stress is early involvement of the anaesthetist. This involvement must be maintained throughout pregnancy. We need to plan the type of anaesthesia at delivery. We need to make provision for care after delivery, and we need to have a plan B. Now, I think that every patient with a history of cardiac disease, or a family history of cardiac disease, or perhaps a disease associated with cardiac manifestations such as Marfan's or Ehlers-Danlos, needs early risk assessment. And this can really help you to decide how you're going to look after this patient and also where you're going to look after this patient. Now, risk assessment, this is the CARPREG score. This is the score that this study produced. And it really is a population-based score. And I have to say that it's quite a gross measure. But essentially, if you score more than one of those points, your risk of developing cardiac morbidity during pregnancies, they suggest, is greater than 75%. Now, I think perhaps a more useful assessment of a risk is the modified WHO classification of maternal cardiovascular risk. So this goes through all the classes that we're familiar with: mild, uncomplicated valvular lesions, patent ductus arteriosus being classed as low risk, up to class 4 in patients who have severe valvular stenosis or pulmonary arterial hypertension. And as you go up these classes, the requirement for cardiology input and specialist referral increases. But I have to say that just looking at that, even without looking at that, everyone has a common sense. You know that if you meet a patient who's got severe cardiac manifestations, you know that the cardiologists, perhaps the cardiac surgeons, are going to need to be involved. And for most of us, looking after patients with the extreme end of cardiac disease is really outside the remit of what we can do in our day-to-day practice. Now, one of the problems with cardiac disease in pregnancy is that the features of it, the clinical symptoms that you may see, fatigue, orthopnea, palpitations, peripheral edema, and murmurs, can also occur in normal pregnancy. So it can be very difficult to distinguish sometimes between normal pregnancy and a woman who's got worsening cardiac disease. The previous speaker did mention the increasing use of echocardiography in this area, and I would absolutely share his views. Transthoracic echo is something that's appearing more and more in anaesthetic journals. But one small point of caution I would make is that the gap between obtaining an image and making a therapeutic decision may be too great for somebody who is not used to using transthoracic echo. And I think particularly in pregnancy, where we know that the echo appearances of in a normal woman can change dramatically, I think making therapeutic decisions based on transthoracic echo in pregnancy really needs to be done by someone who's very experienced in this field. It may be an anaesthetist who's developed fantastic skills in transthoracic echo, but I think for many anaesthetists, including myself, my skills in transthoracic echo are currently very embryonic, and I would always seek the involvement of somebody who has greater skills in this area. Now, management during pregnancy, as I said, you need a lead clinician to coordinate care, and this, I think, can frequently be the anaesthetist. We can provide continuity of care. I think you need to decide what investigations and monitoring are required. We've mentioned echo. Fetal assessment, growth scans in particular. The first sign that a woman's cardiac disease may be worsening may be the fact that she's not perfusing the fetus as adequately as she should, and fetal growth may decline. So fetal growth scans are important as part of the assessment of the cardiac picture. In addition, these women may pass on their cardiac issues to their fetus, so the fetus needs to be assessed for that as well. Many of these women may be on cardiac medication, and we know that pregnancy alters the pharmacokinetic response to cardiac drugs, so doses may need to be altered in response to this. And also bear in mind that many of the agents can have an impact on the fetus, so some drugs may need to be changed for other less teratogenic agents. And also, lastly, just mention those women who are on long-term thromboprophylaxis. Again, this might need to be warfarin, as we know is teratogenic, so these women will need to be converted to low molecular weight heparin, and also low molecular weight heparin doses increase in pregnancy, so standard doses may not be effective. Now, mode of delivery. This is some interesting data that's come from the ROPAC registry, published just a couple of years ago now. They looked at mode of delivery in over 1,000 deliveries. They were a heterogeneous group of patients, so valvular disease, cardiomyopathies, ischemic heart disease. And what they found was that perinatal mortality and low APGAR scores were not significantly different. Gestational age and birth weights was lower in women delivered by caesarean section. But between the two groups, whether you were delivered by caesarean section or a vaginal delivery, there was no difference in maternal mortality, postpartum heart failure, or hemorrhage. So the author's conclusion was that vaginal delivery is the preferred mode of delivery for the most part. What about anaesthesia for these women? Well, neuraxial anaesthesia, as we have heard from the previous speaker, if there's no contraindication. And ideally, low-dose epidural, which has the least impact on cardiovascular dynamics, is preferred. A combined spinal epidural anaesthetic for caesarean section can be very useful, using a smaller spinal dose in the first instance and then extending the anaesthesia if the spinal dose does not provide adequate anaesthesia to provide an adequate level. And sometimes it's necessary to, if you want to do a vaginal delivery, it's necessary to induce labour to optimise the timing of delivery in relation to thromboprophylaxis. What you don't want is a woman coming in spontaneous labour who 2 hours ago had her dose of thromboprophylaxis, which would prevent you doing a low-dose epidural. Now, the third stage of labour is a very high-risk time for a woman with a cardiac disease. It's associated with very significant hemodynamic changes and fluid shifts. And one of the big issues around this time is the use of uterotonic drugs to prevent postpartum hemorrhage. And pretty much all of the or uterotonic drugs that we would use have some kind of cardiovascular effects. Ergometrin is probably the worst, and I would suggest to you that ergometrin should be avoided in these women. Oxytocin, if it's used, should be in a low dose, given slowly. And the standard in my institution is to use a 3-unit dose, but to give 1 unit every 5 minutes. An interesting drug that's appeared in the last few years is carboprost. Now, carboprost is a synthetic analogue of oxytocin, and it has, as we know, one of the biggest difficulties with oxytocin is that it has a short half-life, about 5 minutes, which necessitates giving it as an infusion. Carboprost has a much longer half-life in the region of 3 to 4 hours. Studies suggest it has a similar cardiovascular profile to oxytocin, but it does have a much longer half-life. So I wonder if the use of carboprost may be beneficial in these patients, because it might avoid the use of additional uterotonics, such as ergometrin. But there's very little data on that at the moment. Now, one point I do want to mention is fluid balance in obstetrics. We think of these patients as young as fit, and so that they can tolerate, we think of obstetric patients as young and fit, and people that can tolerate fluid loads. But even in the ordinary parturient, one without cardiac disease, there are significant problems with fluid balance. With pregnancy as a volume overloaded state. Coexisting disease such as preeclampsia can make the risks of volume overload increase. Drugs such as syntocinon or the prostaglandins used to manage hemorrhage can further increase the risk of volume overload. And I think that we are reticent to use additional monitoring in these patients because of our perhaps fixed belief that mostly they'll be fine. We're probably less aggressive about instituting additional monitoring to monitor their fluid status than we would be in a patient, say, having a laparotomy. So I think that we, as a community of specialists, we do need to lower our threshold and perhaps be more aggressive about instituting additional monitoring in these patients. Now, I just want to just briefly describe some findings from the confidential inquiry which was published 4 days ago, and I'm going to talk about ischemic deaths. We've changed the formatting of my slides, so it's moved a little bit, but I'm going to talk about SADS and cardiomyopathy as well. So first of all, aortic dissection. Now, aortic dissection has a 25-fold increased risk in pregnancy. And it has a very high mortality with a poor surgical outcome, especially, as I've said, especially in pregnancy. Mostly, aortic dissection occurs in late pregnancy or the puerperium. Now, this is a vignette from the confidential inquiry which describes some of these points very nicely. A woman in her third trimester was admitted to the obstetric ward with severe chest pain that required opioid analgesia. She was an inpatient for 3 days, during which time myocardial and ischemia, pulmonary embolism were excluded. She continued to need opiates for her severe intermittent chest pain. Eventually, she was sent home, and she died at home. She collapsed and could not be resuscitated. And the post-mortem showed extensive ascending aortic dissection with hemopericardium. Now, I think when a pregnant woman presents to you with chest pain, I think the first thought of any clinician is pulmonary embolus, pulmonary embolus, pulmonary embolus. And I think increasingly we're starting to think, well, it could be ischemic disease as well. But I think that it's not simply enough to exclude pulmonary embolus or ischemic pain. If a woman is requiring opioid analgesia to relieve her chest pain, there must be very significant pathology going on here. And I think just to send a patient home without a definitive diagnosis is cavalier in the extreme. The next case, an obese multiparous patient was hypertensive in late pregnancy. She was delivered at home by emergency caesarean section. She was hypertensive post-delivery and discharged home on labetalol. A week later, she developed severe back pain associated with incontinence and leg numbness and paralysis with marked hypertension. She had cold mottled peripheries. Cauda-equina syndrome was considered but excluded by MRI. No further attempt was made to make a positive diagnosis until several hours later when she collapsed with hypotension and profound metabolic acidosis. An urgent CT scan was planned, but it didn't take place for a further 2 hours, by which time she was in extremis. When the CT scan was done, it showed dissection of the whole descending aorta, and although she was transferred to a regional centre, she sadly died. Now, I think this case demonstrates very nicely a point that I want to make. Increasingly in medicine, we hear about the role of human factors. And one of the aspects of human factors is fixation error. Now, when a woman presents with hypertension, we think that and neurological signs, when a woman presents with neurological signs, as anaesthetists, we're thinking a problem with the spinal cord, cauda-equina syndrome, and we don't think outside the box. And I think this represents a clear example of fixation error. A fixation error occurs when a practitioner concentrates solely upon a single aspect of a case to the detriment of other more relevant aspects. And we know that it can delay diagnosis. And it can also stop us changing a management plan from plan A to plan B when plan A fails. Now, fixation errors have been implicated in a whole host of medical disasters over the year. The most recent one I can remember in my own hospital a few years ago was an obstetric patient who was tachycardic post-delivery. Her tachycardia increased and increased and increased, and she was diagnosed with an SVT. And the people involved did ECGs and called cardiologists. But they didn't look at the whole patient, and they didn't look outside the box. And of course, she didn't have an SVT, she was actually bleeding. So I think that we've got to be prepared to consider other diagnoses. It's very easy just to dismiss neurological symptoms in an obstetric patient as something related to the spinal cord. But cardiovascular problems can also present with neurological problems. And I think the other point I want to make is that as anaesthetists, we're always taught to have a plan B, when things go wrong. But there's no point in having a plan B if we don't have a willingness to change to that plan B when things go wrong. Now, sudden adult death syndrome with a morphologically normal heart. Now, this is an emerging entity where people, usually young people, collapsed from cardiac arrest. And you're probably wondering why I'm mentioning it to you, because as an anaesthetist there would seem to be little that we can do about it, and that's true, but there is one aspect I think that has some relevance. This seems to be increasing in prevalence. This is data from the UK, which shows, you can see over the last 10 years or so, there's been a huge increase in the number of women who've died from this complaint. But I want to point out that this is not because the death rate is actually increased. It's much more likely to be due to the fact that we're actually detecting these women and they're getting the right post-mortem diagnosis. Now, the post-mortem diagnosis is important because many of these can be related to congenital genetic factors. And if a woman dies and has a PM and the PM diagnosis is sudden adult death syndrome, the woman's family must be referred for testing. But the reason I want to mention it to you as an anaesthetic and internists is this case report. A young woman from North Africa had a cardiac arrest during labour. Chest compressions and manual ventilation were commenced, but no attempt was made to ascertain her cardiac rhythm. She was moved to theatre for a perimortem C-section. She was intubated and the baby delivered before defibrillator pads were attached. She was in VF. Now, if you're going to reverse a cardiac arrest situation, VF is I don't want to say easiest, but it's the one most amenable to reversal. Despite multiple shocks and prolonged resuscitation attempts, she could not be resuscitated. So the point I want to make to you is that if you are ever in this dreadful situation, early defibrillation is of the utmost importance, and each minute that you delay defibrillation reduces the likelihood of survival. And I think in this situation, the overwhelming desire is to do a perimortem caesarean section. And I think that, we think, well, let's try and at least save the baby. But remember, you're doing a perimortem caesarean section in that situation, not primarily to save the baby, but primarily to try and improve the mother's chances of resuscitation. But there's no point in doing that if you're forgetting a very, very important part of resuscitation, and that's defibrillation. Now, maternal cardiac arrest is a very topical subject. There's lots of work coming out about it at the moment. And I just want to tell you about this very nice study. This is it's a simulation study that comes from America, and what they did was they looked at 26 teams of 2 providers doing managing maternal cardiac arrest situation. And they had a primary outcome of the percentage of correctly delivered chest compressions, and a secondary outcome of looking at the number of interruptions in chest compressions, because we know that chest compressions is a key part of resuscitation. So what they did was in one group, they kept the patient, they did resuscitation and the perimortem caesarean section where the arrest occurred. And in another group, they decided to move the situation from the labour room to the operating theatre. And what they found, unsurprisingly, was that in the stationary group, where resuscitation and perimortem caesarean section was carried out in the same place, the percentage of correctly delivered chest compressions was much greater than in the group that was moved. Similarly, the number of interruptions in chest compression, you want continuous chest compressions, you don't want to interrupt it, was much lower in the stationary group. So I think the take-home message here, and something I think you should take back to your own units, is that if you are in that dreadful situation of having to perform resuscitation on a pregnant woman and do a caesarean section, you should be prepared to do it there and then. And I would urge you to consider developing emergency caesarean section packs that you can bring to the patient rather than bringing the patient to theatre. Now, just to finish off, I just want to mention ischemic cardiac disease in pregnancy. Now, depending on what case series you look at, this seems to have quite a variable incidence. A study from America suggests an incidence of 3 to 6.2 per 100,000 deliveries, but in the UK, a more recent incidence suggests it's much lower than this. Now, these are the risk factors for cardiac disease. Now, if you look at these, older age, perhaps not smoking in Kuwait, but all of these other factors, these are increasingly prevalent in all of our obstetric patients. So I think that we shouldn't for 1 minute think that our obstetric patients aren't at risk of ischemic cardiac disease. an older woman had an uneventful pregnancy until 34 weeks when she developed chest pain. The pain was on and off for 3 days and radiated to her back and left arm. She was a smoker and had a family history of cardiac disease and hypertension. She was called an ambulance and she was given Entonox by the ambulance man. And when she was assessed in the emergency department, no one asked about her risk factors for cardiac disease. Despite an abnormal ECG, which they attributed to her being pregnant, she was discharged and she was found dead in bed at home a few days later. And I think that we really need to, up there with pulmonary embolism, we used to consider that our number one cause of chest pain in the obstetric patient. I think we need to give it equal billing, the risk of myocardial ischemia. So just to summarise, cardiac disease in pregnancy does represent an extremely heterogeneous group of conditions. Current management strategies that we have are largely generalised based on population studies, and we really need to individualise our management. We need multidisciplinary teamwork required to ensure good outcomes, and the anaesthetist, I believe, should be involved at an early stage in our increasing role as peri-obstetric physicians. Thank you.